Yeah, Alan is a clinical associate professor at the University of Pennsylvania in Philadelphia. He was an MD degree at Tufts, intern resident at Montefiore, and fellow in rheumatology at Montefiore. And he's going to lead the Thieves market for us.
So thanks very much, David. I spoke to the people presenting today, and I said to everybody, we need to stay absolutely on time. So we planned for 50 minutes, so we'll have you out on time 50 minutes from now. So just a few quick comments. The first, I really want to echo what Artie Kavanaugh said. I think David and Pam McLean need to be complimented for a truly exceptional conference. I mean, you know, I think every speaker so far, and I'm sure the ones coming up tomorrow, hit home runs, including the pinch hitter a few moments ago. So we're going to present 5 cases, and I selected them really because of their particular educational value. These are unusual, but not entirely esoteric problems that I think we need to be aware of, and I think a number of them, you'll agree, are problems that we're not fully aware of as adult rheumatologists in typical clinical practice. So we're actually going to present 5 cases. The last 4 are going to be presented by fellows, and by a show of clapping at the end, we're going to select the best one, and I think there's a prize for the one best case. But the first case was sent to me by an attending. I didn't think it was fair to have him part of the competition, but I thought it was such a good case that I asked him to present this case. So the first case is going to be presented by Ray Pertuzzi, who is an associate professor of medicine at the University of Massachusetts. And again, I thought his case was particularly educational, and I asked him to present it. So Ray?
Thank you very much, Alan. This is a case that was sent to me by a rheumatologist in rural Massachusetts, and it's entitled A White Lady with a Wild Disease, and there are no misspellings on the slide. So this is a 76-year-old white female who developed proximal muscle aches in February of 2013. It was thought to be PMR, and she was treated with prednisone, which seemed to help. Upon tapering, though, other symptoms seemed to emerge, including erythema and swelling of the ears, and it was sparing the lobes, earache, vertigo, and hearing loss. Now, the rheumatologist who was seeing her consulted an ENT doctor, and she was given a diagnosis of otitis media, mastoiditis, underwent myringotomy, and was treated with antibiotics and improved. But then, after a period of time, she started to experience some weight loss and had a day of tracheal tenderness and a cough. It was a kind of a cheap cough, a very dry, not very significant cough. Her urine, though, consistently showed some occult blood. Now, her past medical history is positive for anemia, intraductal carcinoma of the breast, which was treated on 2 separate occasions with lumpectomy, RT, and HRT. Her medications include Bactrim, which was given to her for PCP prophylaxis because she came to me on 20 milligrams of prednisone daily. She was also on anastrozole, gabapentin, and omeprazole, and some iron. The rest of the history is truly unremarkable. Physical examination. This was a thin, frail, rather cachectic-looking female, but otherwise the physical examination was unremarkable. Now, she was referred to us, like I said, from her treating rheumatologist because she had the cough. He did a chest x-ray. The chest x-ray was kind of read, as they typically are, in a vague fashion, recommend CT. They do the CT, and after the CT is done of the chest, he does a follow-up laboratory test and then gets concerned about what she might have, and he sends her to me. So we'll start with the chest CT, which is on the bottom there. And it was read as bronchiectasis with bilateral nodules and scattered nonspecific ground glass, primarily affecting the right middle lobe and left lingula. Now, if we look at the That's not working. If we look at the laboratory, maybe this one, hang on. There we go. If we look at the laboratory, the main reason why he sent her was the chest CT and the anti-PR3, which was elevated at 2.4. And you see the normal value there. Her ANCA was negative. So he did the ANCA and the PR3 and MPO separately. The ANCA was negative, but the PR